Good evening, America, and a very happy good evening to you. I'm Dr. Randy Fink, and it is time for Fertility with Fink and Friends. I am Fink, you are Friends, and here we are, like we are every Tuesday evening at this time, 5 o'clock on the Gulf Coast in the Central Time, which means 6 o'clock in the East, 4 o'clock in the mountains, and 3 in the West. And I'm just, gosh, a few minutes late after the top of the hour, so please forgive my tardiness, but it is so nice to see all my friends joining in here. How's everybody doing tonight? I will say that we are lacking a couple of connections tonight, so we've got my Instagram here, and that's Randy Fink MD. We've got New Life Fertility right here, and we've got LinkedIn and YouTube and the First Fertility Network right here, but we're missing a couple of Facebooks. And so if you know anybody who likes to watch on Facebook tonight, those Facebook feeds are not connected due to technical issues beyond our control. But aside from that, Tuesday is my favorite time because it is the time we get together and talk about all those things that are important to us, things about making a family, things about getting pregnant, things about women's health, all that stuff you have on your mind. Please share with us all tonight because you are in the right place. Tonight I am live in Pensacola, Florida. I'm a fertility gynecologist at New Life Fertility. We also have offices in Mobile, Alabama, and Panama City. And I also work with the fine folks at the Missouri Center for Reproductive Medicine, which is in St. Louis and in Tulsa. And it's just great to see everybody here tonight. Let's see who is joining. We've got Sheila here. Elena is here. Good evening, Elena. Nice to see you there. Kowser. Oh my gosh, Kowser is 8 weeks pregnant. You did it. Congratulations. Oh, wow. I am so happy to hear this. This is such wonderful, wonderful news for you, and I hope you're feeling well. We'll talk about that early pregnancy stuff here in just a second, but meanwhile, hi to Allie and Burdick. Marianne is here. I think that says Monino, I believe. Hi, Tara. Good to see you. Mrs. C.R. Tyler is here, as is A. Clark and D. Meyer. D, you were the first to join here tonight, so thank you for being there on my feed. Hi, Grace. Nice to see you there also. So you know that early pregnancy thing, huh? Feels wonderful, doesn't it? Yeah, it feels great. People, have asked the question, why is it that being early pregnant, you say the nicest thing there. You say, thanks so much, doctor. I never missed your podcast, which helped me through my entire journey. I really sincerely appreciate that. That is truly the kind of feedback that keeps me going. People ask why is it that we feel so crappy when we're early in pregnancy, and I think part of that may have to do with the fact that it's kind of trying to get you used to things to come because pregnancy is not a good time for most people for feeling great, and the people who say, "Oh, I felt so wonderful in my pregnancy," they're often the outliers more than the norm, for sure. Nausea tends to start to set in around 7 weeks, and it peaks around 9 to 10, and is usually starting to go away by the end of the first trimester by 12 weeks. And so I hope that will be the case for you. Breast tenderness is often the very first thing that shows up there, and after that. The bloating and the fatigue is certainly there in the beginning, all that kind of stuff. So why do we have it? I think it's just it's an evolution thing. It may be trying to help us to get used to all that stuff that's kind of coming down the pike. Kowser says it's natural pregnancy after a laparoscopy. A small septum was removed and a small endometriosis burn, but I do have Hashimoto's, and I'm using low-dose naltrexone. back. There we go. I think the mic is back. We're having some microphone issues there. When to stop low-dose naltrexone? I stay on it. I have folks stay on it through the first trimester. There are some practices that actually recommend that you stay on low-dose naltrexone even for the entire pregnancy. But to be honest with you, there is not a lot of good data to support that, and I think it's actually probably overkill, because many people later on in pregnancy, especially around the time of delivery, will start thinking about maybe wanting to have epidural anesthesia for their delivery. And if you are on naltrexone, that low-dose naltrexone can block the opiate effect of the numbing medicine and of the pain medicine that they're able to put in that epidural. So generally speaking, I say, into the first trimester, unless there are special circumstances involved. Also, folks with Hashimoto's are often on steroids, on prednisone, and usually we start to taper that by 10 weeks so that you're off of it by the first trimester. Ruby has joined over here and says, I'm a big fan. Well, I certainly hope you're a big fan. You better be a big fan. That's my daughter. So, if you're not a big fan, you're in trouble. You're grounded. Thank you for being here, and good evening. And also a special hi to Aaron, who is out there tonight. If you're still watching, thank you for being here from, I believe you're in Milton tonight. It looks like Vivin Son XO, I believe. Quetskin Jillian, I think that says. Elena's over here as well. Still talking about Hashimoto's. Kauser says, my TSH jumped last week. It was 1.9 and now it's 8.1, but the free T4 is good. My vitamin D is low. Will that cause any complications in pregnancy? To be honest with you, most people's vitamin D is low. So we try to correct that, because it can have an effect on egg quality, and it can also have an effect on implantation. So it seems like you have succeeded past both of those issues, and so that's very good news. There's no harm to supplement your vitamin D in pregnancy. Vitamin D is also involved in calcium metabolism, and so I think it's probably a good thing, because that calcium is making teeth and bones in your baby, in addition to kind of keeping yours happy and healthy, as it were. Hashimoto's is a situation where it's a kind of a funny name if you're not familiar with it, but basically it's autoimmune thyroiditis. Autoimmune thyroiditis, which means that you have developed an antibody against your own thyroid gland. And so what happens in that case, we check it here. I check it for fertility patients, because it doesn't necessarily mean that you have some thyroid disease, right? It is not an indicator of a disease state, but rather it's a way of kind of standing in the doorway of your immune system to be able to see if the lights are on and if anybody's home, if people are milling about. That's kind of the way I think about Hashimoto's. But some people who are making that autoantibody against the thyroid, it's a common reason that you will develop hypothyroid later on in life. And if yours just jumped up to 8.1, sometimes that antibody can block the function of your own thyroid. Sometimes it can bind to those receptors and block and make you hypothyroid, or it can bind to those receptors and activate the thyroid, actually make you hyperthyroid. And so that's a good thing to check that free T4 to tell us whether that is something that's known as subclinical. So certainly in your case, you're going to want to monitor that thyroid, probably at least once per trimester. There's a lot to be said, really about Hashimoto's and about those anti-thyroid antibodies, because many people have those antibodies and they don't feel well. When I was in the hormone optimization side of things, I would always check that antibody because it was a signal to ask ourselves whether we wanted to be whether we wanted to be trying to optimize the thyroid gland, usually with some natural thyroid or what we call desiccated thyroid. If you take that result into an endocrinologist, a medical endocrinologist, they will often say, what are you here for? You don't have a problem. Get out. It's not something that needs to be treated necessarily. Counselor, in your case, gosh, your thyroid peroxidase antibody was 900. That's a very high number. So well, you got pregnant naturally there. If we were doing, putting an embryo in, I would absolutely really want to give you some prednisone for that. But there is some controversy over whether that antibody means anything. And there's a website that you might be interested in looking at, and it's called Stop the Thyroid Madness. Excuse me. Stop the Thyroid Madness. There's actually, I believe, a book of that title as well that talks about autoimmune thyroiditis, about Hashimoto's, and really it can be blamed for an awful lot of things, and how many of those things are real, it's hard to say, because thyroid symptoms often mimic those of just kind of everyday life, fatigue and just not feeling well, or cold intolerance, or constipation, slow moving, things kind of associated with hypothyroidism. The website suggests that really so many of these things that we experience in our world really can be related. But if you ask a medical endocrinologist, they'll tell you that's not a thing. I really do think that it's something there. Does it affect the baby's brain or growth? And the answer is no. Fortunately, it does not. It does not. And in fact, as far as thyroid goes, we used to say that we very meticulously wanted to keep your thyroid hormone level between a 0.5 and a 2.5. And if your thyroid was outside of that range, then we were aggressive about treating you to try to bring the thyroid into that range. Well, what we know now is that really doesn't make such a difference. It doesn't really make any difference in terms of outcomes. As long as the thyroid hormone level is normal, then you are in okay shape. So you do kind of want to keep on top of that TSH there. Yeah, for sure. Jody Hoffman is here, my dear friend Jody up in Missouri. Shadia, good evening, as is KN Lee. Fertility with Ari is here as well. D asks, what does low-dose naltrexone do? And that's a really good question. Low-dose naltrexone is something that has been used in the anti-aging community for really a very, very long time. The first question is, well, what is high-dose naltrexone? We're talking about low-dose naltrexone. What does naltrexone do in its high doses? You may have seen on all the ambulance and police shows that when the paramedics come upon someone who they believe to have overdosed, there's a medication called Narcan that can be given that immediately blocks the opiate receptors in the brain. And so you can have people who are getting chest compressions. They're getting CPR. They're literally unresponsive, not breathing, because they overdosed on heroin. They get a dose of their Narcan and boop, they wake right up. It's really impressive to actually see that happen. And nowadays, you can kind of see that sort of thing on TV. Naltrexone is really an oral version of what you might find in that Narcan, an oral version. So it's a pill. And in its high dose, which is a 50 milligram tablet, if we gave let's say a heroin user a 50 milligram tablet every single day, it would block the receptors. They could shoot up as much as they want to, but they wouldn't get a high from it. So it's a disincentive to using it, that sort of drug. Low dose naltrexone is typically a 4.5 milligram or less dose. And what it does is that it temporarily and partially blocks the opiate receptors in the brain. And when you do that, what happens is that it causes a reflex increase in your endorphins. And your endorphins are those feel-good chemicals that we have in our body. And so with that reflex increase in endorphins, that has a significant effect on boosting the immune system in the places where you want to boost it and suppressing the immune system in places where you don't want it. So I think of low-dose naltrexone in the fertility world as something that is used to sort of turn down some of the bad immune response and to turn up some of the good immune response. In the anti-aging world, it's that immune response thing that really makes a difference. Folks who are taking it over the long term, I'm told you never get sick, like you'll never catch a cold. It was a big thing when, during COVID times, that people were on low-dose naltrexone. They said that, they weren't going to get sick. I don't know that that's true. I don't know if that was actually a thing or not. But so that's kind of how it works. We use it as a kind of a more general anti-inflammatory, as a general anti-overstimulated immune system kind of thing. So I think in Kauser's shape there, the situation there, it was because, gosh, that autoantibody level was so high. If you were trying on your own to get pregnant in that scenario, I wouldn't put you on prednisone, because prednisone is not a benign drug. It's not something that you want to stay on for long term. You do it on, kind of for short periods, not when you're just kind of trying on your own. So I think that low-dose naltrexone is a very good thing to do in that situation, because it's kind of being able to blunt some of the immune response that's happening at the level of the immune system, and in your case in particular, at the level of the thyroid. Let's see, Pui is here tonight from St. Louis. Canley said, trying to watch on the Facebook side, but not pulling up if you've just joined. Facebook, we're having communication issues with Facebook tonight. So unfortunately, the New Life Fertility and the MCRM Facebook sides will not be live tonight, but we'll try to get the broadcast over there so that they can broadcast it later. And we will have that repaired for next time. So actually next week, I have to tell you, I am not going to be here. I'm taking a little vacation, getting to go see my old friends in Colorado, going to see my son in Colorado, who is in college. And so I'm going to be off for a little bit. There will be no Fink and Friends next week. Oh, boo, I know that makes you all very sad. Yeah, you'll live, won't you? No Fink and Friends next week, but that's because getting a little bit of a summer vacation before school starts again, really for everybody else. La Mujer is here. Good evening. Ms. Tyler says our GC's vitamin D level was low at 25 during the baseline for her FET. She's taking 4,000 in her prenatal. Can her vitamin D level negatively impact implantation? And the answer is potentially yes. Potentially yes. Now, I will tell you that if I checked everyone's vitamin D out there, and I used to do a lot. In fact, in my fertility practice, we do check everyone's vitamin D. But in the hormone optimization world, when I was doing this, people who weren't trying to get pregnant, we would check vitamin D all the time. Almost everybody is vitamin D deficient, or at least insufficient, and that is, it most commonly falls. The number that we're looking for is a 30. 30 is the lower limit of normal, and I'd say probably 80% of the people that I test are between 20 and 29. Some people in the 15s to 20s, and sometimes I even find people with a level of 8 or 9. And I'm like, how are you even walking around out there? How are you alive with that number? So almost everybody is low, but yet people get pregnant anyway. So is it a thing that prevents pregnancy? And I'm going to say no, it probably isn't. But is it a thing that can make outcomes suboptimal? And I'm going to say, yeah, I think it really probably can, especially since you are, you're investing an awful lot into having a gestational carrier. You've invested a lot to make these embryos, and then you're going to be placing these embryos into your gestational carrier. I would like to see at least a normal hormone level, at least a level of 30 before I went and did embryo transfer. So I would hope that the fertility practice where you're doing your transfer would have treated that. I would strongly advise it. Now, 4,000 units, okay, that's approaching. I tell people, look, the minimum I want you on is 5,000 units a day. You may be able to kind of rapidly increase that by a prescription level, which is 50,000 units once a week. Problem is we don't really absorb that so well. But there's just kind of a little bit of a ways to go. But yeah, Miss Tyler, I think if you had the opportunity to correct that and at least put that vitamin D level into the normal range, I would do it. Now, the optimum range for vitamin D as it pertains to, wellness and anti-aging is actually between 60 and 80. So, it can go much, much higher. And sometimes I'll even see people with levels of 100 if they have been supplementing for a while. But I would increase it a little bit beyond 4,000. But yeah, I'd sure like to see that being normal before you did an embryo transfer. The Daver Lee is here. Good evening. Britt Morell, we've got Aaron. Hi, Aaron. Nina Buena is here. Kayan Lee says, I am coming to the office next month for my FET. I got my meds in the mail today. A little bit nervous because we had a successful first round 4 years ago. So praying really hard that it works out again. I think you raise an excellent point there. And that is that it's hard to stay positive, isn't it? It can be very difficult to stay positive when you've had things happen to you that are not what you're after. Let's say you've done an embryo transfer and it didn't stick. Or you've had to go through fertility treatments and make embryos and have to do things like embryo transfers. It's different and it is difficult to stay focused and to keep your eyes on the prize. I think you are absolutely justified, that's a good word for it, to be nervous about it. But my suggestion is, to the best of your ability, be gentle with yourself. Because you got pregnant before, right? You did this a few years ago and you got pregnant, which means you can do this again. It's going to happen if you want it to. Really, the question is, well, all right, well, how many hoops do you have to jump through to get there? So really, in your case, the outcome should not be in question. It's just a question of what do you have to do to finally get to that point. And that becomes a frustrating and a lonely and a frightening place to be. So, I think you are absolutely right to be nervous about it. But I would like for you to continue to feel very hopeful, especially since you're coming to see me. That makes me very, very happy and frankly quite honored. It's 1:30 and at 5:30 here on the Gulf Coast, which means that it's time for the 5:30 Fuzzies with Fink. And if you have not been here for this program before on Fink and Friends, this is the point of the show where we all just kind of take a moment and give our thoughts to everyone out there who is in need tonight, particularly as it pertains to fertility. It's a hard process to go through. It's a difficult place to be. We just said it's scary, it's frightening. It can create immense anxiety. It can create tremendous depression. It can really send you down a rabbit hole that makes you so focused on something that you lose sight on all those other good things around you. But most of all, it makes you feel isolated and afraid. And so, what I like to do here at this point is to make sure that you know that you are not alone in this. And it's not just me, it's not just your clinic, it's not just your nurses and your doctor. I think that everybody really who watches this program is the kind of person who would almost literally give the shirt off their back. They would absolutely lend a shoulder to anyone out there who needs it, who is going through the same process that you've been through. And you know what? It's not just about fertility. It may be about family. It may be about relationships. It may be about work. It may be about school. Whatever it is, you are not alone. And this is the time that we all stand together as one community and send out those positive vibes to everybody tonight who needs them. Because, as I am fond of saying, tomorrow is a new day and it is full of all new adventures. Wherever this twisted road is taking you, you're going to get to the place that you need to be. So, positive vibes. Let's break the internet with kindness right now. Please press the heart button. Send out some good vibes and good spirit to everybody who needs to hear that tonight. And that, my friends, is the 5:30 Fuzzies with Fink. But people do ask, well, what can I do tangibly to make a difference here? You know, it's nice to push the heart button. It's nice to thank you for all those hearts there. That is very meaningful. But what can you do tangibly to do that? Well, you know what? People here may not, it's hard to identify, people and to be able to connect with people and talk about your own experience. But, the world is not a kind enough place. You see these random acts of kindness, do one of them. Smile at a stranger. Give a piece of candy to a kid. Stop and pet a dog. Do something nice for the world. Stop and sniff a flower. Pick that flower and give it to somebody who looks like they could use it tomorrow. Just do a little something, because that's how we can tangibly make a difference. By one smile at a time, one heart at a time, one act of kindness at a time is how each and every one of us can really change this world. And that's just my 2 cents worth, not to sound overly simplistic, but I really do believe that. And thank you for your kind wishes tonight to everybody out there who needs it. I appreciate your participation there. Hey, Tracy in Miami. Midgie has joined us here as well. Elena asks, and we also have JK, it looks like, and Lauren. Hi, Lauren. Elena asked, out of my 8 embryos, 1 was sent for PGT testing. Does this mean that if I do another stimulation, the results are likely to be similar, I guess because of my age, at 41? Okay, so thanks for bringing that up, Elena. You know what? I did not have a chance yet to look at FERT reports from our retrievals last week. Well, so what I try to do each time that someone goes to do another stimulation is that I want to look at how they performed. I want to look at, is there anything that we can do to try to improve the way the body responded to the medication? Can we improve the egg quality? Is there anything that we can do to try to stabilize some age-damaged DNA? So really what happens, it doesn't necessarily mean you have to have another appointment, but you identify, at least in my practice, you identify to your coordinator that you'd like to do it again, and they will automatically kind of give it back to me to take a look, do a little research into your personal case, and to see if there's some tweaking that we can do to try to make for a better stimulation, to try to make for better egg quality. Now, that said, even if we don't do anything different, if you go to do another stim, oftentimes what happens is that we do better and better in sequential cycles. The egg quality often improves. Why is that? Well, when we do things like back-to-back cycles, some people would say, oh, no, I think, I'd rather my body needs a rest. I'd rather give my body a rest here. That must be more important. And actually, the evidence shows us that's not the case. The evidence shows that doing back-to-back cycles, the medication that you use in one cycle will continue to help you to recruit eggs in subsequent cycles, and that effect can really last for, it starts to diminish over time, but potentially up to 2 to 3 cycles, or 2 to 3 months I should say, after that first egg retrieval. So even if we don't do anything different, we typically do see some improvement. But there are some things, Elena, that we can look at to try to improve egg quality. But you are correct. Now, you did really well in terms of making eggs, but the uphill battle that we knew from the start was going to be the egg quality that is there at 41 years old, because those eggs have been hanging out. They've been hanging out in the ovary since the day you were born. And so some of that DNA becomes less stable over time. So that's really the biggest thing we have to go up against. But the good news is, the first question is, do you have normal eggs in your body? Absolutely, you do. 100%. You do. We just have little control over what you're coughing up in each cycle, or what eggs, your ovary is going to give to us as part of that stimulation. So that's the part that can be frustrating. But the fact that you made a bunch of eggs, the more eggs you can make there means the greater the probability that at least one of those is going to be normal, or 2 of them, or 3 of them. And the more the merrier. So back-to-back cycles is a good thing. Not something that you should fear. Now, of course, your pocketbook fears it, as always. It's an expensive process. But I'm pleased that at least one went out there for PGT testing tonight. So fingers crossed there, my friend, for sure. Tara asks, with PCOS and endometriosis, do you recommend a natural IVF cycle? Well, I think what you may mean there is a natural FET, or a natural embryo transfer cycle. So when people talk about natural IVF, they're talking about doing IVF in an unstimulated cycle. In other words, in a natural cycle where your ovary is going to produce the one egg that you may make anyway, retrieving that one egg, bringing that one egg to the lab, fertilizing it, and seeing what you get. I don't recommend that, right? Because the whole process of IVF is really power in numbers. The more eggs you get, the greater the probability you're going to get one that's normal, that ultimately results in getting you a baby. The fewer the eggs we get, the lower the chance that we're going to have normal eggs. So you're kind of working against the science if you do natural IVF and only go to retrieve a single egg without stimulation. Now, a natural cycle embryo transfer is a different story. So there's a couple of different ways that we can do embryo transfers. One way is the medicated cycle, and most of the cycles in the United States now are medicated cycles, because that was what was, that's what they did since IVF was invented, and that was where we give you the estrogen, we give you the progesterone, and that stops your body's own ability to make it. And it allows us to control all those variables. So we're controlling your estrogen and your progesterone there, so that everything happens exactly the way we want it. That's a medicated cycle. There is a natural cycle, which is where we let your own hormones take the front seat. You make your own estrogen every month anyway. You make your own progesterone every month anyway when you release that egg. So why not let your body do what it's supposed to do? We monitor those levels anyway. We watch the levels, and if you need more, we give you more. Many people prefer a natural cycle, mostly because you don't have to do the cursed progesterone injections, right? Which is, no small thing, to not have to subject your gluteal muscle to the progesterone and oil. But the evidence shows us that they are at least equivalent, whether it's a medicated cycle or a natural cycle. I personally like a little hybrid there, and that's what's known as a modified natural FET. And in a modified natural, we give you some ovulation induction to make sure that you're going to produce an egg that is going to get released in a timely and predictable fashion, rather than just letting your body kind of do its own thing, which sort of throws caution to the wind. You're not really sure about timing. That changes things a little bit. So I prefer a modified natural with some ovulation induction. Now, the thing is there, T. Andre, is that if you have endometriosis, okay, and if you've done suppression for the endometriosis, then trying to do a natural cycle after suppression is often not effective. Oftentimes, your body is still very sluggish in its response. And you may just not release an egg. You may not create that egg, make the normal hormones, and release that egg in a timely fashion if you have been suppressed with Lupron or with Orilissa. So I do not recommend a natural or a modified natural after endometriosis suppression. But as long as you will ovulate with ovulation induction agents, right? And some people with PCO are resistant to ovulating, but as long as we can make you ovulate and you haven't done suppression, there is no harm to doing a natural or modified natural cycle. And again, I like the modified natural. And in fact, there's some evidence that shows us that it may even be better than the medicated cycle, but there is not enough evidence out there to say, yes, it is better, everybody should be doing it, or, my gosh, everybody would be doing it, and they're not, you know. Using a medicated or a programmed cycle is a little bit more predictable, and that's kind of the way I would think about it. It's predictable in the sense that you know exactly when you're starting your medication, you know when your monitoring days are going to be, you know when your embryo transfer is going to be. We can pick the transfer day and then work backwards from that. So that's what you get with a medicated cycle. There's really no guesswork to the timing. But is there a problem with the natural? No, and we do know that those pregnancies often have a lower incidence of blood pressure related problems. So if you came to me and said, well, in my first pregnancy, I had preeclampsia, and I had to get delivered early. I had preeclampsia. Or I was on magnesium for a while, and that didn't feel good, did it? Preeclampsia is a pregnancy-related blood pressure problem. And if that's the case, then I would say, gosh, a natural cycle or a modified natural is really a good thing, because it's going to lower your risk for that happening again. And that's my 2 cents worth there on that. Hi, Easy E113. JK says, Dr. Fink, what is your position on add-ons for FET, for example, Neupogen? And I would say it depends. I am not a believer in the add-ons for every person. And there are some programs who will provide a laundry list of extra medications to take. The thought being that, well, we can't test everybody for everything. And if we can't test everybody for everything, then we might as well treat everybody for almost everything, because it's not going to hurt most people, and it may just help some people. And that's the rationale behind that. But, you know, the American Society for Reproductive Medicine says don't do that. It does not recommend these broad immune add-ons for the general population. But there are specific scenarios where they are both indicated, and some where, you know, they're really absolutely necessary. Now, Neupogen is one of those things that has a very narrow application. It is very specific of what it should or is intended to be used for. Certainly, if you have an autoimmune issue, what Neupogen is going to do, it's going to take your white blood cell count and it's going to make it kind of go through the roof. Your white blood cell count normally sits, you know, at under 10,000 or less, it's going to make it 30 to 40,000 is going to be your white blood cell count. So much so that you may get a blood test done and somebody's going to look at that and say, oh my God, what is happening? Well, that's its intention. It's designed to make that blood count get higher, that white blood count get higher. But it can be used in folks who have had a difficult time growing their lining, especially in the form of a Neupogen wash. A Neupogen wash, which is taking a little bit of that Neupogen medication and placing it inside the uterine cavity, can cause help the endometrium to grow and get thicker, believe it or not. And sometimes there's an indication for people who have, let's say, chronic endometritis, a chronic inflammation in the uterine lining, which we can't seem to eradicate. That's an indication for it. But the routine use of Neupogen injected, and it's expensive, you know. And that's a thing. I have not seen any compelling evidence that it helps in the general population, so I tend to avoid it. There are some things that I use much more freely. Prednisone, I use much more freely. Low-dose naltrexone, I use much more freely. I do a PRP wash in the uterine lining. We use intralipid, for instance, very rarely. And it has not made any difference in pregnancy outcomes. So, you know, that's kind of where I stand on that. But specifically Neupogen, I am a little wary of because of its expense and because of its effect on making that white blood cell count so high. Hello to Zenaida in South Florida. Good evening, my friend from Doral. I hope your evening is wonderful. And the same to everybody else. I am so appreciative of you being here tonight. We've got another 15 minutes or so in the show. This is Fertility with Fink and Friends, and I am Fink. You are friends. And every Tuesday evening, except for next week, we get together here and talk about all these important things. I am a fertility gynecologist at New Life Fertility in Pensacola, Florida, with offices also at Panama City and Mobile, Alabama. I also see patients at the Missouri Center for Reproductive Medicine in St. Louis and in Tulsa. Yes, we are available to you no matter where you live. We do virtual consultations. We can help no matter where you are and no matter what you're going through. I'm happy to talk to you. Give us a call, and that's New Life Fertility or the Missouri Center for Reproductive Medicine. Let's see, Randy Hill, the wonderful and talented Randy Hill in Miami has joined here tonight, or at least did a few minutes ago. Randy, if you're still on there, I've been thinking about you, bud, and it's nice to see you here. Sick of Pineapple. I like the name. I like that. Hi, Plant Honeys. Good evening tonight. Hey, Miranda. And let's see. JK says, thank you. I appreciate your knowledge and positivity. It is my pleasure. But I got to tell you, speaking of positivity, you know, again, it's so easy to lose that sense of self and to lose the positivity when you don't know what's going to happen tomorrow. You know, you don't know what's going to happen with your treatment because there are no guaranteed outcomes here. It's easy to lose hope. It's easy to kind of be overcome by anxiety and fear. And the one thing that I really do, I have to say that I feel very strongly about is that hope matters. Hope really does matter, because when you feel beat, when you feel kicked around and like you have been through this process and you're, you know, going through the motions, and you know what you're doing is that you're trying to protect yourself from being hurt again by not being positive, by not being excited. You're trying to, you know, it's a self-defense mechanism. But I really think that changes your vibe. It changes the way your body reacts to things. It increases your cortisol levels, which is our body's stress hormone. So to the extent that you can, try to stay hopeful. I really think that there's a tangible difference from that. Positive vibes gives you positive betas. And I really, honest to God, think that that's true. Positive vibes, positive betas. D asks, what's your recommendation on the lining to be for a transfer, either fresh or frozen? Still kind of learning all this. So most studies tell us that we want a minimum of a 7 millimeter lining in order to do an embryo transfer. So what's happening there is you're getting some estrogen. Either we're giving you that estrogen, or under normal circumstances, your body is making that estrogen as you're developing a follicle in your ovary or an egg that is ultimately going to be released. You've got some cells in your ovary that surround your egg, and they're called granulosa cells, and those granulosa cells are where your estrogen comes from. So in a natural cycle, or in what happens, every single month that you're going to have a period, your granulosa cells are making estrogen. In an FET, we're giving you that estrogen either in the form of a pill or a patch, right, in order to build up that uterine lining. The job of the lining is to be a nice, spongy, warm, juicy place for an embryo to implant. It's like a little, I describe it as your baby blanket. That's your baby blanket right there. So what that's what the estrogen is doing for you, 7 millimeters. And additionally, what we expect to see when you look at that is that it has a particular appearance by the middle of the cycle. It's what's called trilaminar or multi-layered, trilaminar, 3 layers. And what we can see there is, and I always say, somebody told me once, it looks like Mick Jagger's lips. I should take a screenshot of that. This should be my, the headshot for this episode. The lips, you've got the I'm not going to do that again. I can't go there. I don't like the way that looks. You've got the top lip, you've got the bottom lip, and then you have the interface between the top and the bottom. Top layer, bottom layer, and the interface between, that's 3 layers. 3 layers, or a trilaminar endometrium of at least 7 millimeters, tells us that it is adequately estrogenized in order to be able to to take a pregnancy. Now, once you start using progesterone, that 7 millimeters will start to compact. It starts to kind of get pushed down. Think of it as you put some dirt in the planter, and then you kind of tamp it down. That is to be expected. It may get less than that. So it is not what is the measurement of that endometrium at the time of transfer, but rather what is the measurement of that endometrium when you start your progesterone, or in that case, basically when you would be ovulating. There's some evidence that it may even be 6.5. That difference in a half, but half between 6.5 and 7 is that's a hard thing to actually measure. And there are some studies that even show, there are some people who may not be able to make that lining, but as long as it is adequately, as long as there's blood flow going to it, that may be the best you can do. So I've done embryo transfers in people with 5.5, 6 millimeter linings because that's the best they can do. As long as we saw some blood flow going to it, that is what we got. And since that's what we got, and in fact, they got pregnant with it. But in general, in the general population, 7 millimeters would be what we're looking for at the minimum for that lining. JK, apparently you think that my face there was funny. My face is funny enough without having to make trilaminar lips. You know what I'm saying? Dunklin Donuts. Hello, the Dunklin family this evening. So let's see what else we have going on here. We've got some different feeds. I've got my Instagram, which is right here, and that's Randy Fink MD. This is New Life Fertility here. We've got LinkedIn. We've got YouTube. We've got New Life Fertility. We've got the First Fertility Network, which we're all a part of here. But we're missing our normal Facebook posts this evening for New Life and for MCRM due to some communication problems. So if you know anybody who's trying to reach us on the Facebook side tonight, tell them, come on over to Instagram, come on over. I really should try to do these things on TikTok as well. I don't TikTok a whole lot, and I haven't quite figured out the way to do TikTok lives, but I need to talk to somebody who's more knowledgeable than I am at that. TikTok would be another nice place to sort of be able to do this process here. Let's see. So I got another question here that came into me on paper, and that was, can you please explain what endometriosis does to keep me from getting pregnant, and how do I know if I have it? And that's a good question, because endometriosis, it's a tough one. Back in the olden days, in the earlier days of fertility practice, I like to say that you would have a laparoscopy scheduled before you ever even met the doctor. Having a surgery, a laparoscopic surgery, to go looking for endometriosis was really part and parcel it was part of the entire workup for fertility. Such a strong opinion that endometriosis was a thing. And it is a thing, but what we realized ultimately is that a lot of people were having surgery that really didn't change the outcomes of pregnancy at all. So now we say, gosh, I don't, and still there are a lot of folks of a maybe a little different generation who feel so strongly about laparoscopy that they still push these laparoscopies as though it's going to make some big difference. Endometriosis classically is a pain syndrome, right? Endometriosis is where that lining of the uterus that normally sloughs off, instead of going out the door, works its way up and implants inside your pelvis. Classically, it creates dysmenorrhea, pain with your periods. It can create pain with sexual intercourse. It can create pain with a bowel movement. It can have an effect on your AMH, on your ovarian reserve. It can cause endometriosis cysts in your ovaries. It can, definitely change the anatomy, can create scarring. Really, the most common presentation of endometriosis, though, is silent endometriosis. And that is someone who has no idea that they have it. And we can test for that now, particularly in the fertility world. We can test for that non-invasively by doing a little endometrial biopsy at the right time of your cycle. It would be the time that you would be implanting your pregnancy. So typically between cycle day 21 and 24 is the best time to do it. We look for a marker that's called BCL6. And that's a test, if you'd like to read about it. It's called Receptiva. And Receptiva has a website, receptivadx.com, and that will tell you about Receptiva. It's a little straw that goes in the uterine cavity, sucks out a little piece of tissue, and they look for that particular marker. And what that marker, which is highly associated with endometriosis, tells us is that your body, or potentially the endometriosis itself, is going to be blocking your own progesterone. And it's that progesterone that's the most important hormone to maintain the pregnancy. And if you're blocking your progesterone, then you're not going to implant. Your pregnancy is not going to work. Or maybe it implants, but it won't continue to grow. This is something that we want to know about. So let's say that you have a euploid, or a chromosomally normal embryo. That embryo can give you up to a 65% probability of pregnancy, unless your BCL6 marker is positive. And if your BCL6 marker is positive, then that takes your 65% number and it drops it down to about 12%. So that's the real deal. It does not make sense. We do not think it is useful to empirically test people for this in the general population. It is much more sensitive. It has much more meaning in folks with recurrent implantation failure, or folks who have recurrent pregnancy losses, or for that matter, even folks who potentially have real honest symptoms of endometriosis. So I do not suggest that you go out and ask your provider, hey, I feel completely fine, but I want to have that test just because I want to know. It makes a lot more sense to, the results from that, because there can be false positives and false negatives. The results make a lot more sense when taken in the context of infertility, particularly embryos that don't stick. So that's kind of what that means, and that's a little bit on endometriosis there. Hi Sheila, and hey Mary, good to see you both this evening. And folks, we are going to be about out of time tonight. I am so appreciative of you coming to be here with me and spend your Tuesday evening at Fertility with Fink and Friends. Remember, next week I will not be here. There will be no program next week due to summer vacation. I get a little bit of time off. Going to go to Colorado and see my son. So I will see you back in 2 weeks, and I hope you will be willing to join me then for more Fink and Friends. And until then, please remember, every step forward with love, every step forward with kindness, and every step forward with hope. Because tomorrow is a new day, and it is full of all new adventures. This fertility thing is not the book of your life. It's just a chapter. And what are we doing? We're rewriting that damn thing together. So until next time, Dr. Randy Fink saying thanks so much, and good night. See ya.